The purpose of this episode is to explore common health and well-being strengths and challenges for people with Down syndrome. The content discussed here is not meant as a substitution for direct medical care with relevant professionals. Rather, we hope to share new and little-known information so that families and supporters can be well-informed when accessing medical care. Your child or student's medical or educational professionals may have recommended different practices or procedures that are specific to them. Do not modify or change your child or student's treatment or therapy plan without consulting with your care provider.
Today on the Lowdown, a Down syndrome podcast, Dr. Lena Patel gives us lowdown on helping people with Down syndrome use medical equipment. Over to you, Hannah and Morilla.
Thanks, Jody. Hi, everyone. My name is Hina Mahmood, and I'm the Senior Occupational Therapist at the Down Syndrome Resource Foundation and co-host of the LowDOWN podcast. I am joined today by my awesome colleague, Marla Folden, who is a speech-language pathologist at the DSRF. Hi, Marla.
Hi, Hannah.
How are you?
I'm good. How are you?
Good, thank you. I'm really excited about our guest today. But before we kind of get into our topic, just for our listeners out there, we would love for you to hit the subscribe button and leave a review of our podcast on your chosen podcast platform. And remember to check out our episode pages for additional resources related to each episode topic. You can also follow the DSRF at our website, www.dsrf.org. And of course, we are on Instagram and Twitter, and you can follow us by following at DSRF Canada. So on today's episode, we will be talking about medical equipment, such as eyeglasses, hearing aids, and of course, the Cpap mask. And really the importance of adherence to help your child and or adult wear their medical equipment. You know, there are a number of reasons why it can be difficult for individuals with Down syndrome to consistently use or wear their medical equipment. Sensory issues, behavior. I'm sure, Marla, you have encountered this in your sessions with hearing aids and glasses.
Oh, yes. It is. It's really a challenge, and it's something that we see all the time. So I would never want a family to feel like, wow, why is this happening? Because it's almost universal. Kids will come into my room, those glasses come off. Sometimes they hit the wall. Sometimes they get stepped on. And,
sometimes they get thrown in the garbage can and you can't find them later.
Actually, that did happen once. I mean, that was clever. One student
she was very clever.
Her glasses in the garbage on the way out, and it took us hours to find them again. There were many phone calls. That was awesome. Yeah. Except it really wasn't for her family, but it was really clever.
Yes, exactly.
So it comes up all the time, for sure.
Yeah, absolutely. And then I think the important thing is also to recognize why they're doing that. So, and how we can help, because always need to know the why. So, and that is exactly why we're so excited to have our guest join us today to discuss not only why this is a challenging process for our kiddos and individuals with Down syndrome and their families, but what can we do to help them buy into this process long-term?
Absolutely. And so today we have Lena Patel on our episode, and she's a doctor of psychology and an assistant professor of child and adolescent psychiatry at the University of Colorado School of Medicine. And she practices at Children's Hospital in Colorado. That's in the States. Dr. Patel provides consultation with schools, parent training regarding managing of challenging or unsafe behaviors, developmental evaluations, toilet training, and desensitization to medical devices, which is why we have her on here today with us, because this includes things like hearing aids and Cpap machines. And she's worked with hundreds of individuals with Down syndrome, so lots of experience to draw from for us, and everybody from ages 1 to 25 years old. And outside of her clinical work, she's presented to numerous organizations across the country and internationally. And she also conducts research on clinical issues that impact those people with Down syndrome. Welcome, Dr. Patel and Lena. Thanks for coming.
Thank you. No, thank you so much for having me. I'm really excited about our conversation.
we are excited to talk to you. We love to chat with people who, kind of do Down syndrome all day like we do. So this is a treat for us. It's our tradition on the Lowdown to start with 5 secret questions where we get to know our person that we're talking to a little bit better. So do you fancy indulging us with that?
Sure.
Okay, fantastic. So question number 1 is, what are you currently reading or listening to?
Oh my goodness. That's a really great question. I'll be honest, most of the stuff that I read is research articles related to Down syndrome. So I have various books on my nightstand that I would love to read, but I think that the thing that makes me most excited is hearing about work that other people are doing to, kind of make my job even easier when working with individuals with Down syndrome. So I would, kind of be boring in my answer and saying probably research articles related to Down syndrome.
I think that's okay. I also have the wishful reading stack of books. That doesn't get attended to as fast as I would like, but there's work reading to do always, for sure.
Yes.
Question number 2, do you have a go-to sort of self-care routine after an end of the day in the clinic or the lab? What do you like to do?
At the end of the day, I am just a huge music buff. Like, I just really feel like music is like the thing that solves like all world problems. So usually for me, it's maybe taking a short walk while listening to music, or even just I have 2 kids and that are, almost 10 and 7. And we frequently have dance parties because they're sadly doing remote learning and really despise remote learning. And so I think that for all of us, a little dance party with some really good music is always a happy way to end the day.
Oh, absolutely.
So since you're a music buff, because we had another guest who was a movie buff, I have to ask this question. Favorite band or favorite album of all time? I know it's a very hard question, but...
Yeah, album of all time would be really difficult. I actually think that I'm going to tell you, like, our family band is U2.
Yeah.
So I feel like
mine too.
It's like on repeat.
I can assure you, Glenn's like in the background being like, yeah, because Glenn and I also love U2. So that's awesome.
Yeah, my kids are both play instruments, and what's hilarious is their teacher like lets them pick what songs that they want to learn how to play. And I would say that if anybody guessed what it would be a U2 song. So
love it.
That's fair.
Yeah.
It's very danceable. So
danceable.
Totally get it. Oh,
yeah.
Wonderful. Question number 3 is, what is your favorite sort of family vacay destination? Do you guys have a place you like to go?
I mean, living in Colorado, we have, I would say like the easy access one is the mountains. There is just such a natural like sigh of relief that happens as you're driving into the mountains and spending time there. We were fortunate enough to take a family vacation, obviously pre-COVID, to Kauai, and it was our first time to be there. And it is, again, like one of those places where it feels a little magical to be there, because you just get the opportunity to like, not just decompress, but like, it's not a high intensity place. It's, super, low key, eat at the, gas station place that has the best food, which sounds really weird, but amazing, and doing a lot of hiking. So I would say that those are probably two of our favorite places.
Yeah, I mean, that's a real relaxation holiday for sure. It's not a New York City go.
Yeah.
But at this point, I think we all need a relaxing holiday for sure.
Yeah. I think for us, like, our days are just so go that, like, I mean, I love New York City. I love places like that, but definitely for a vacation, it has to be like a beach, low key, no schedule kind of place.
For sure. Oh, Kauai sounds great right now. We're currently having a dreary Vancouver rainy day, so that sounds really good. Okay, so I'm going to take over for the last couple of questions.
Sure.
If you had to delete all the apps on your phone, but keep only 3 apps, which ones would they be?
I know this is a hard question.
Oh my gosh. You guys are, yeah, I know you said this isn't a test, but man, the pressure. I have to look at my phone to know like what's actually
Go for it.
So I can only keep 3, you said, right?
Yes, exactly. You got it.
Oh my gosh. I have to add like some boring ones and then some good ones. I think the photo app, I feel like for me is a really important one. I think that when you can't have a moment where you're like just naturally having a really good day, like looking at old pictures and, kind of like the joy that it brings you. I feel like that
for sure,
would be a favorite.
Yeah. If you want to make this easier, you could like the built-in apps that come with the phone, we can leave those. Those are already there. It's the ones that you download. So I should be more clear with that question. So like the things you download, if you could only have 3.
Okay. So I would actually say you actually are helping me out a lot. Perfect. Because one of the ones I would have said would be my podcast app, but it came.
Oh yeah, no.
Yes, that's a freebie.
You're good.
Netflix.
Excellent.
I feel it's like a guilty pleasure. I hate that I love it so much, but
I don't think anyone has to feel guilty about Netflix nowadays. It's a survival thing. So
it really is. I just think that I spend way too much time doing that. So I think that would be one. I think because I have a super type A personality, I have this app called Meister Task that organizes me and tells me like what thing I need to get done with the most immediate deadline. So
nice.
Unfortunately, that's me geeking out. I love it. And a music app is already on there, so I don't have to count that one. Man.
Are you a big social media person?
I am and I'm not. I kind of like Facebook. I'm kind of old school. I have a Facebook account, and there was actually a 3-year period where I deleted it because I just needed to not be connected. And I think that mental health is so connected to all of that too. So
100%.
So as a result, I never got like Instagram or anything like that either. So the only other one I would say that I have is like, I actually am trying to develop a hobby in taking photos. And so I have this thing called Nikon SnapBridge, and it's like attached to my digital camera. And so again, it just like, there's a theme. Apparently I love photos.
Awesome.
So I would say that that's actually something I downloaded.
Amazing. I can imagine the photo opportunities in Colorado too. Like there's so much beauty everywhere. Yeah.
Yeah,
great.
For sure. Yeah.
Okay. And our last question, if you could pick one skill, could be anything that you think everyone should have, what skill would that be?
Oh my gosh, I'm going to use my psychologist brain here. And I would say like the power of self-reflection. I think that so many amazing things can happen if you can just be open to like, taking a moment and reflecting on not just like your own contributions to the world, but also like, the impact that you make on people because of how you perceive, how they're presenting themselves too. So yeah.
Perfection. Love it. I
have all these like geeky, like psychologist responses to everything. I didn't realize
you're talking to the right people. So you're good.
Such a huge part of my identity, I guess.
Yeah. And I think self-reflection is such an important thing too. Cause I mean, I'm sure Marla can agree, as therapists, we are taught that to self-reflect on how we work with our clients, how we are as therapists every day. And it really does make such a big difference.
It really does.
How we provide services. So we totally agree.
Otherwise you would never get anywhere. First roadblock, you'd be stuck. And there's plenty of roadblocks. So you have to be able to think your way around them for sure.
Exactly.
Yeah, absolutely.
Yeah. Awesome. Love it. Okay. So now we can kind of get into our topic of the day. Marla had mentioned that you have been working, at the clinic at practicing at Children's Hospital, and that you've been working with individuals with Down syndrome for a very long time. Can you talk a little bit about where you're currently working and what your day-to-day looks like when you're seeing your clients?
Yeah. So I actually recently had a little bit of a shift in my job. So one of the things that I'm really focusing on right now is to actually provide telehealth services for families individuals with Down syndrome who live in rural and frontier parts of the state. So people who don't have immediate access to coming to at our actual hospital and being able to get support services. I mean, we're so lucky that we have such a integrated system with so many, services. But not a lot of people, there are places in our state that don't have access to that. So my day-to-day is actually a mixture of research time specifically with individuals with Down syndrome, and then also building this clinic that will serve that patient population. So in Colorado right now, again, due to COVID, most services are being provided via telehealth when possible. And so I'm fortunate that I've been able to do that, which actually has given me like this whole different perspective on how to provide treatment interventions. Yeah. And it's kind of funny because I think that we get really, really focused on what we've done for such a long time that, I'm not by any means saying like, oh, COVID is a blessing or anything like that. But what I will tell you is that it forces us to get creative and sometimes like just needing to be in, get out of our rut. So we've been able to provide like live coaching, which families will say to me sometimes, like, I wish I could take you home, like, and have you kind of like in my ear. And I think that is absolutely like such a real reflection of life, right? Like our kids in particular, get so good at presenting in a certain way in a certain place. And so when they come to our treatment intervention rooms at the hospital, they get into this routine of like, I know what I'm supposed to do here. But then the families, like, even when they do it beautifully there, have a really hard time when they're at home. So I think that having them, families put in wireless earbuds and then placing the camera in a common area and then live coaching. I mean, what a concept, right? But it's been, I think, a game changer in the types of interventions and supports we can provide for families. So, it's a mixture of direct care, coaching parents, coordinating with other providers. I feel like our kids, are so complex and unique in so many ways that if we're not talking to community therapists and schools and things like that, we're really I feel like in my job, I'm not doing a good enough job unless I'm doing, translating some of the things we're working on with a family to those other environments. So it's kind of a combination of coordination of care and talking to providers and working directly with the family. And because I work in a medical facility, really, I don't need to be the expert in medical issues with Down syndrome, but I certainly have become quite savvy with knowing when those things impact behavior as well. So
yeah.
I hope I answered your question.
And I'm so glad that you brought up sort of the silver lining of telehealth, because I have been frankly astounded at how well some of my students who I didn't think would be able to handle it have done over telehealth and being able to pay attention to me on a screen, etc. But also just to get your eyes on what's happening at home so that you can give recommendations that actually are effective for their daily routine and the space and all of those factors which we don't normally get to see. It's been huge. I mean, it's been just a real game changer for the way that we've been able to do our clinical work. So glad you brought that up.
Yeah, for sure.
So what have you learned in your years of experience working with individuals who have Down syndrome?
Wow.
It's a big question, I know.
That is a big question, but a really important one. I think that one of the most important things that I've learned is that the variability we see in the general population is just as reflective in the population of individuals with Down syndrome. So while I have developed some pretty successful techniques in working with this population, there's always a variation or a change or something that you have to do that's different from what you expected, right? So, I think that what I've learned is to be really creative and patient with the fact that even when I feel like I might be an expert in with regard to a specific topic, that I'm really not, because at the end of the day, there are personality characteristics that still, play into this and then, throw you for a loop. And you might have like the perfect perfectly planned out intervention strategy. And then you try it and you're like, well, that did not go as I anticipated. And having to, kind of stay in it and tweak and change and modify and observe and listen. I think that our as a speech therapist, Marla, you probably, appreciate this piece so much that so much is said without words. And I think that we sometimes forget that. And so we underestimate what the people we care about, what their capabilities are, because we just assume that if they can't tell us verbally, then they must just not understand. Yeah. And so having to be really creative and coming up with strategies that, kind of fit that profile or just, really support based on what skills a person has versus focusing on what skill they might not have at the time.
Yeah. Or sometimes it's about finding the avenue so that you can figure out what skills they have.
Yeah.
Right? Where, you think maybe they don't understand this thing at all, but we have to try a few ways to make sure, because, just talking about it is not a solution for a lot of our students to show their skills.
Exactly. Yeah. And not assuming that they don't have a particular skill until you've given them the chance. So like that presuming competence thing that we talked about in an earlier episode, I think it's so important because many times people will just see the label or they'll just see from a physical perspective, okay, they have Down syndrome, so they're probably not going to be able to do this, this, and this. But in our experience, we know that that is not the case most of the time.
Not at all.
So, right. It's how we teach it, not what we're trying to teach, right? It's what modifications are we making? And, to the point of the topic of today, I mean, desensitization, I think that it feels really scary and sometimes like, so heavy and so hard that it's easy to kind of go, well, they just can't learn it versus being like, no, we just have to be way more creative in how we come up with strategies 100%. To actually address the issue.
Yeah. And I think COVID was a really good learning experience for parents because I've had so many parents say, oh, they're never going to wear a mask. But with the proper approach, with the ample amount of practice and the correct way of teaching it, I mean, I'm shocked at some of my clients who are wearing a mask during our entire OT session. Yep. Right? Yeah. So it can be done, but it just takes time and it has to be taught in a very specific way that works best for their learning. So,
yeah. And I'll confess, like I feel really guilty at times for having thought this, but like same thing. I've been shocked when I was doing in person for a period of time. And we were wearing masks and shields and patients coming in and wearing their masks the whole time. And I was like, oh my gosh, I needed a reality check because I underestimated this person's abilities. And I do this day in and day out. So how crazy is that? So I definitely think that it's been an eye opener.
Absolutely.
And it speaks to I think everybody is doing it, and we might assume that our students are not aware of that. Oh, they are. Like they notice that everybody else is wearing a mask, and that certainly helps when the expectation is there socially and universally.
Yeah,
our students can rise to that challenge for the most part. Really,
exactly. Yeah. Well, this kind of flows beautifully into kind of our next question. So what are some of the reasons why wearing and adhering to medical equipment is so challenging for individuals with Down syndrome?
Yeah, that's, there are so many different pieces, and it's such a complex, thing to think about. You mentioned some of them. I think that, we kind of underestimate how much our kids have these sensory sensitivities that make it really difficult to like physically get used to the sensations that are very different from what you're used to. I think that, the neurodevelopmental profile of an individual with Down syndrome is, that our kids really don't like change. I would argue that I don't know very many people that like things when they change, but I think that for individuals with Down syndrome, I think the particular issue is that when things change, then I don't know what the expectations are. And so the rigidity is actually a kind of a coping mechanism for that. And so, and then we're just, because of we're really used to using these traditional ways of communicating new information that may not necessarily fit really well with an individual with Down syndrome, then we make the problem even worse because we're saying, hey, I know you don't like change, but you're going to have to do it anyway. And I'm not going to give you the roadmap for how to make that change feel more comfortable for you.
Yeah.
You know? And so I think that that's a huge piece of it as well. Definitely cognition and understanding why equipment is needed. You know, if you had a neurotypical teenager, you might be able to explain, hey, this is the reason why you need to wear it, and this is the benefit you'll get from it. But it's, you know, for a lot of our individuals, it's not that they can't get to a point where they appreciate the difference and the benefit. It's just that it might take a longer road. And the aversiveness of the situation is so much more significant than the benefit, if that makes sense. You know, that person perceives that they're like, yeah, I'm not going to go through the rough stuff in order to get to the part that you're telling me is going to be really good for me.
So great. Yeah.
You know? Yeah. And so I think that makes it really difficult as well. You know, when you can't have kind of this longer term goal to work towards for any of us, that's really hard, right? I use the example of teeth brushing all the time. Like, you know, we have a lot of kids who have a really hard time with brushing their teeth or having their teeth brushed. And I say, like, our kids are not thinking like, hey, if I don't brush my teeth every day, I'll have long-term like dental pain and surgical procedures and potentially like lose my teeth and all of that. Like, that's not something that they're accessing in the moment. The feeling of having your teeth brushed is so aversive that that's all our kids can focus on. And that makes it more difficult. We also know, related to the neurodevelopmental profile, that, you know, there's a portion of the brain called the hippocampus that is, you know, responsible for short-term memory and really kind of holding information and then transferring it to long-term memory. We know that neurologically, that part of the brain is just structured differently and doesn't work as efficiently as in a typical person. And so if you think about it from that standpoint, when we say like, people with Down syndrome are very here in the moment, and have a hard time thinking about future things or issues. That's not because they just choose not to. It's because their brains really function that way. And so if I'm in a, you know, situation that feels bad, I am, and I have a memory that doesn't allow me to kind of access times when things got better after overcoming this hurdle, then why would I not resist, right? Like, I mean, of course I'm going to resist those types of situations. So I think that really makes it much more challenging for our individuals with Down syndrome too.
Yeah. Yeah. That's
I think I'd like to draw a little comparison here where, you know, we're asking a lot of these students, and sometimes I don't think we acknowledge that. There's a lot of equipment in general that we're asking these students to comply with. You know, lots of people have glasses. Sure. Do lots of people have glasses and hearing aids and need further equipment for sleeping? Not really. So it's not just that it's really aversive, it's that it's a lot of stuff. And when you think about, you know, everyone's own individual experience of getting used to wearing a mask every day and how much people have complained about that because they don't want something on their face. You know, we're asking glasses, hearing aids, mask, and Cpap machine. We're asking a whole other level of, you know, just deal with it from students who have a harder time dealing with it. Yeah.
And attempting to navigate your environment. That is also very predictable while wearing all these things and learning, you know.
You know, I think that two things that it makes me think of. One is I also like have such a, like, you know, empathy or such a emotional connection to families who, you know, we're talking about how hard it is for kids, but then we also, and as all therapists, we all give goals to families. We all tell families, like, here's what you need to do, but we're telling them from our perspective. So now our families have like 20 different things that they have to work on with their kids to get them used to it, versus if it was just one discipline or one person that's working, you know, telling them to. So I think that there's, you know, family factors too that certainly impact this. And it's not because of a lack of motivation or a lack of desire. It's a lot. It's a lot every single day. You know?
Oh, sure. And we don't give the most recommendations to the kids who are doing the best, you know, who are coping the best. We give the most recommendations to the kids who are having the hardest time.
For sure.
So does everybody, other therapist, right?
For sure.
So the kids who can cope the least get the longest laundry list of things you got to do, this and this and this and this and this, which is this sort of inverse relationship from the ideal, which is if you're really struggling, we'll just give you a bite-sized amount.
For sure.
Manage.
For sure.
Yeah.
And I think when you talked a little bit about how they're not necessarily long-term thinkers and not thinking about how this is going to, like I've had this conversation so many times about the CPAP. It's just like, they don't understand that the discomfort and the anxiety of a CPAP now can help them so much later on that it just, it's like that battle is hard for parents too, because that logic isn't working. So you know, the anxiety of the CPAP is way more salient than knowing that, oh, I'll have a better sleep. That means that I can function better in school. I won't be as tired, you know? So just providing parents with that bigger picture, I think is super important so that they can understand why it is so difficult.
Yeah. I think so too. And I think that, you know, not just in my hat as a person who works with families to get kids to wear medical equipment, but just generally speaking, there's this huge burden of parents feeling like they're not good parents, right? Like that if I can't get my child to wear this equipment, then it's on me. And, you know, professionals are going to look at me as if I failed my child versus going, hey, this is a way harder job than just saying, hey, here's your new equipment and go put it on and don't, you know, complain. It's way, way more difficult than that, you know?
Oh yeah. To be the person there every night, making sure that CPAP stays on, or they're putting the glasses on 600 times a day. You know? It's harder.
And I think, you know, going back to the sensory piece too, not only is it something new, like the immediate sensation of it being like on your face or in your ear or whatnot, but, you know, we're not even talking about like the aversiveness of a new sound, right? So like having a hearing aid is like, you know, we think of it as like, oh, it's so amazing. Now we can hear everything. But if you've never heard those sounds before, that's not exciting. That's terrifying, you know? Or having, you know, like most of our kids who have obstructive sleep apnea and are getting used to wearing CPAP, you know, when we talk about techniques related to that, you know, I can elaborate on this, but, you know, most of our kids have such significant apnea that this is not a low setting of pressure in your face. I mean, it would be like literally like a high pressure fan, like blowing air in your face, and you're supposed to breathe through that. I mean, it's pretty crazy. It's a pretty crazy experience for our kids. And so I don't think it's not a little bit of it. It's a lot, right? It's not a hearing aid that you are, you know, I mean, some of our kids have mild hearing loss, so it's a slight correction, where then the problem is maybe they don't hear a huge difference. So they're like, why are you making me wear this? And then for the really severe hearing loss kids, it's like, whoa, that is stressful. I don't like that sound. I don't want to hear that sound. So you're kind of like stuck either way, you know, with it being much harder.
That experience can be aversive enough where they're just like, I'm not even going to try it a second time. No, thank you.
Absolutely. Absolutely.
Exactly. Another aspect that I've noticed with some of our older clients is that a feeling of, and I hate to use this word, but you know, like the feeling of wanting to be normal. So if I'm wearing hearing aids or glasses, or if I'm wearing AFOs or whatever, anything that's more visible in terms of a medical equipment, like what are your thoughts on navigating that aspect, like getting them to understand that, you know, that it's okay if you have to wear them, that, you know?
Yeah. I mean, I think that, you know, again, this goes back to like, you know, us underestimating the level of experience related to identity formation and, you know, adolescence. Like we think of our young adults and adolescents with Down syndrome as, you know, kind of being a little more aloof to like what's happening around them. But the reality is they really start to notice the differences and the pressures related to that. And, you know, what we again know about the neurodevelopmental profile of individuals with Down syndrome is that they, even though they may experience these, you know, developmental stages later, they are still happening. So adolescence is still adolescence, whether you have Down syndrome or not. And so the thing that I try to really focus on is how, you know, really being able to validate, this really is hard. And this is something that makes you feel different. And here's the community that you can feel like you fit with. Right. And so, you know, we have, you know, storybooks that talk about other people who have hearing loss that they may look up to that, you know, also wear hearing aids, or, people who use CPAP, same types of things, but being able to kind of give a glimpse into the life of someone else and being able to say like, that there are similarities and that this may feel like it makes you more different. And I get that. And I understand that. And this is not unique to you. And this is, obviously we know that these types of medical issues are more prevalent in individuals with Down syndrome, but they're not solely characteristics of individuals with Down syndrome. And so being able to kind of normalize it in that way, I feel like is kind of what I focus on.
Absolutely. And I think it's complicated too by the fact that you can't just say, hey, why don't you want to wear that for most of our students? Because they can't just tell you, oh, well, I haven't seen anybody else in my class wearing it, so I don't really want to. That's not a likely response that you're going to get. So it does what looks like just straight non-compliance. That's why we say there's always a reason, and we need to do the digging to find out why. Yeah,
for sure. Yeah.
So before we kind of get into some of the more specific pieces of medical equipment, in our experience, and often parents will trial equipment, and if the process isn't going as planned, they may feel that, it's never going to work. So what is your advice to those parents and caregivers to kind of get them on board with the trial and error process? Because obviously there's going to be a multitude of strategies that may need to be implemented to figure out what works best for their loved one. But what would you say to those parents?
I really say slow and steady wins the race. And I feel like that's even more true with individuals with Down syndrome. Our families, I think, kind of are like hearing from other providers and professionals who maybe, everybody has advice to give, right? So people are kind of like, well, if you do this, then this is going to make it work. And for our kids, I think it's just not that simple. And so I think that, I see myself as like the cheerleader of, 5 more minutes is better than 5 minutes ago, like, when they weren't wearing it at all. So I really try to stay focused on, helping families to see that piece is that you're still making progress. And that if you jump too far ahead and too fast, our kids are so powerful in their resistance that, they're going to make it way harder for you to ever get to a point where they are going to be using it full time if they have a bad experience related to it. So to me, like, it's not just about increasing time and increasing usage. It's the part of the strategic piece of that is going so slow that it's always building on successes versus having a moment where you have, a pretty big resistance and then being like, we can't do it. Because I find, I don't know about you guys, but I feel like a lot of the times when families say like, I don't feel like they'll ever wear it. The majority of the time it's because they pushed hard and fast right off the bat. Yeah. And so again, if you're thinking about all those things that we talked about are factors that make it more difficult for individuals with Down syndrome to get used to wearing their equipment, well, of course, they're not going to do it then, right? But if we can kind of be very strategic about it, like that's what I try to tell families is baby steps are still steps in the right direction. And if we can kind of stay focused on that, and then I try to really be a big time cheerleader, right? Like I do think, and not because I'm trying to be like fake about it. I really do believe that adding any little bit of time is actually something that's going to result in more exponential gains as we move along because the kids feel successful too, right? Yeah. And they experience it in a positive way.
Yeah. And it reduces like the chances of it going backwards too. So if you're slowly going forward, the likelihood of them going backwards also decreases a little bit.
Absolutely.
So do you typically recommend, like, how do we get started with something? And I'm sure this will come up with each individual sort of piece of equipment. But, let's say somebody gets glasses. And first we want to see a baseline. We like data. I like data a lot.
I do too.
So I, my sort of thought on that, and I'm not an expert in this at all, would be to say, okay, let's put the glasses on and just see how long this kid will wear them for. And maybe it's 10 seconds or maybe it's an hour, but then you have some kind of baseline for where you're starting from. And then if your next step is going to be, 20 seconds or if it's going to be an hour and 2 minutes.
Yeah.
You know what I mean?
Yeah.
Is that kind of what you would do?
I do. So even in my notes, my like progress notes for my patients, like I have a spot that says, initial response to equipment introduction. And so, I'll say for, Marla, like I would take even one step back in saying that I just take the equipment out and wait for a little bit. Yeah. Wait for a little bit to see, are they curious about it? Do they immediately go, no, 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 or, move to the other side of the room? I had this kiddo who had a pretty bad experience with Cpap and came to me after they had already trialed, use of Cpap. And I will tell you that mom, pulled the mask out, and this kiddo, it still like hurts my heart to think about him. In that moment, he went into a corner and he just started crying.
Oh no.
And the strategy that had been used, and, again, this family, amazing family, lovely family, but what they had been told was you just have to make him wear it. And so they had an older sibling that was holding the mask on this kiddo's face.
Oh my gosh.
And I was like, of course he would react this way. Yeah. Of course he would have such a horrible relationship with his mask. He doesn't know what it's for. And people are forcing him, to wear it. And I will say, and not to only share successful stories, but I will tell you that this kid, his mom, after just 4 or 5 sessions, she came back and she was like, he tells me to put it on every night and he wears it the whole night. And we wake up in the morning and he tells me to take it off and we are good to go. And it was, so I think it is important to take that step in just saying if I put something foreign on and I have the experience, then it might be even more stressful than I anticipated. Mm-hmm. So, being able to kind of just see what's the initial reaction. Yeah. Some kids will let me put equipment on them right away and some won't. And I think that comes too with this slow process of I'm holding the glasses. And if they walk over and they lean forward, then I'm like, oh, okay, they know what this is for. Then I do absolutely do what you're saying, which is see at baseline how long they can wear it. And then we kind of come up with the strategies related to how to increase the amount of time.
Mm-hmm. Mm-hmm. That's really good to know. And I think sometimes what will happen is even things that we would think are not a big deal. Let's say they already had glasses, but now they have new glasses. Mm-hmm. And that is worth a start over, kind of, to say, okay, to us, I mean, if you have glasses, you get new glasses here and there, and it's kind of, you take a day and get used to it. And for our students, it's not that.
You're right. You're right.
Yeah.
I have kids who will even actually wear their old glasses with no issue. If their parents hand them the old ones, they'll put them on and it's no problem. Yeah, but it's the new ones. I mean, especially if there's bifocals or any addition that is now I'm trying to navigate this new way. And for our kids who, have a more difficult, rightfully so, have a more difficult time with change. It feels like a bigger leap than what we would anticipate that it would be. Yeah.
I'd like to talk a little bit about hearing here, which is, buddy of speech and language.
Yeah.
Can we talk a little bit about some of the issues that come up and how often they're coming up in your practice that you see either hearing loss or hearing related issues? Can you talk a little bit about that?
Yeah. Yeah. So obviously, hearing loss occurs quite frequently in individuals with Down syndrome. There's, some question about, whether the testing for hearing loss is behavioral, right? You have to understand the instructions and then be able to respond appropriately to what someone's asking you to do. And so, if you're not going under anesthesia and then having, an evaluation of your hearing that's not based on the behaviors, and you kind of question sometimes also well, what degree of hearing loss is there? And I think parents a lot of times question it because they'll say, well, they seem like they function fine on a day-to-day basis without, any significant problems. And I think it is just much more complex than that. So I think that's even that piece of let me help you to understand your child's hearing loss, so that then you have motivation to make this a priority and how it affects things like language development and communication and, understanding instructions and all of those things. So I feel like that comes up a lot. I also think that, this is going to sound strange, but something that I feel like I experience a ton is because of the phenotypic differences, the differences in in ear structure and, facial features, that one of the biggest barriers that is not necessarily sensory related, but kind of can fall into that category, is that hearing aids don't fit very well. And so if they don't fit well, then you a lot of times have like the feedback from air, touching the hearing aid, or they'll fall out. Like, so it's not like I don't want to wear them and I refuse to wear them. It's like, it's really uncomfortable when you have this thing hanging off of your ear because it can't stay looped behind your ear. So sometimes, like when we're talking about the initial assessment, it's simply, does it fit, right? Like, does it even stay on in the way that it's meant to stay on? And then we can kind of tackle the other issues. So I feel like, I'm not sure if I'm answering your question, but I think that, that those are some of like the initial things that I come across. The other big one that I feel like, I really try to, again, be strategic about is there's the component of getting used to the hearing aid in and of itself in your ear. And then there's the part of the sound. So is there a way, and we do this, is let's start with just getting used to it being in our ear with no sound amplification. And then the secondary piece that we can work on is getting used to the sound being there, right? So that's another thing that I noticed, that sometimes kids will actually do pretty well with having the hearing aid in their ear. But then when the sound is introduced, that's when it's a little bit more, we have to be kind of a little bit more strategic about it.
Yeah. Very gradual. Yeah.
Yes.
I think you brought up a really good point about the fit of things. It is essential that our families are connected with somebody who can look into that in terms of an audiologist who can actually find something that fits. Because what you were mentioning with, letting air pass the hearing aid, that's that whistling sound that you hear. If you know anybody who has hearing aids, it's high pitched and it is, imagine if it was
not pleasant.
Can you imagine, right? Like that's not pleasant at all. Sounds like a tea kettle. And we've seen all kinds of creative solutions, but it just kind of goes to show what's needed, where we've seen hearing aids rubber banded to glasses to hold them there. And hearing aids are just finicky little things that do great work, but man, are they a pain. They're expensive. They get stepped on, they get broken. So then we have tape and we have straps and we have all kinds of additional things. So we lose these expensive little buggers. It's a lot. And I think taking it incrementally is really important. So you did mention, step one, making sure it fits and making sure that our student can tolerate it physically, sort of as anybody would with an earbud that's turned off. Now, mind you, hearing aids are not as comfortable as earbuds and go much further in your ear for anybody who's wondering how that feels. And then we work on the sound piece. What can we do about it when the sound piece is a real issue? Because the sort of noise to pain threshold that we as SLPs and audiologists think about is much smaller if you have hearing loss. So not only do you not hear things as well, but when you do, it gets painful a lot faster. And that's sensory issues aside.
Yeah. And I think that's where that piece of slow and steady wins the race is like so important to take into consideration, because there is a fatigue component that, our kids might not be able to articulate to us verbally, but they are articulating it to us with their behaviors. So if I've been wearing my hearing aids for like 10 minutes and then all of a sudden I take them out, we may go, oh, that's just behavioral. They just want to take them out because they don't want to wear them. But what we really have to consider is the things that maybe the person's not telling us, which is, man, this hurts. Like, I'm over this. And so that's also just as important when we talk about how long, equipment can be tolerated, is when you introduce sound. It might be that we're talking about, the threshold that I can keep it in my ear with the sound versus keep it in my ear if the sound wasn't present. Right. So it's kind of a whole nother component. One of my favorite parts of my job is I don't need to be the expert in audiology. I get to be the expert in behavior, and I have amazing people that I get to work with who are experts in those other areas. So if that means me contacting an audiologist and from my more, place of ignorance saying, hey, I know that this is our goal for where the sound frequency needs to be. What are the benefits or, challenges or problems that could arise if we started with something that was lower, you know, and then they explained to me all the like nuances of that.
Jargon,
but
yeah,
you know, but I think that the nice thing about that is that working together, I don't have to go, you know, overcome a hurdle just based on my knowledge base. Like when I'm working with other people, like we can absolutely come up with a solution that I may not have thought of because I'm not thinking about it from the audiology perspective, you know?
And I think it's important to, just like you said, that you may not know all the audiology terms or what questions to ask. I feel like parents probably feel like that as well. They don't know which questions to ask. They don't know what the options are. What are some of the, you know, the different fits and everything. So I think that is really important as well to kind of empower parents and arm them with the correct questions when they go to their kiddos' audiology appointments. So
absolutely. And I would say like, even like I know so many families with Cpap who didn't realize that there's a setting for ramping up the air pressure, right? Like, I mean, it doesn't feel like it's going to be a solution for everybody, but boy, if it could be a solution for some people, why not? Right. I mean, I think that that's important to know. Yeah.
And the knowledge translation piece is really essential here in Canada. At least recently, I found that there's a discussion that should be happening that I find is missing a lot, where parents will come to me with an audiology report and they'll say, this is what it is. Seems like fine. And I'm like, doesn't seem fine. We need to talk about this. And did you know that if your student hears like this, that means they don't hear all of these speech sounds? And there's just a lot of misconceptions. And how would families know? But parents have the right to ask for these things to be interpreted and say, what does this mean for my child's hearing? Like, what do they hear in the classroom? What do they not hear? You can ask, and you should ask those questions if you don't feel like you know. And even if you do feel like you know, you might get some surprises in there. So I would always encourage families to ask those questions because, you know, you don't have to interpret that 6-chart document on your own.
Right. And I think that we, you know, like in the age of technology, the crazy thing is that, you know, there are ways that we can actually replicate the loss to be able to help families experience that. So like, you know, I have amazing audiologists that I get to work with, and I had no idea that they had a program where families could hear what hearing loss, to the degree that their child had hearing loss, you know, that they could hear it, right? Like that there was equipment that could help them like understand hearing loss in that way. And in my head, I'm like, why aren't we doing this for every single family? Like, what a great way to learn, you know, what that experience would be like, right? Which then really changes then our level of understanding of when to prioritize something and how important it is, or anything like that. And I think even like for glasses, like, I mean, you know, the little like things that looks like, I always say it looks like a spider's face that you have to look inside of and they flip the little lenses to ask you if you can see clear this way or that way. I mean, you can replicate vision loss that way too. And so I think that that's such a powerful tool to be able to, you know, help us to understand what the experience is when you have someone who can't just verbally tell you that, you know?
And it's really good for building compassion too. Where,
for sure.
You know, I would recommend that for school staff to try out, you know, some of these simulators, the audiology one, the vision one, where you can plug in the prescription or the level of hearing loss and say, okay, this is what this kid is hearing. This is what they can see. Are we as mad now that they aren't complying with everything we say and point to because actually they can't see or hear it? You know, it's great for building compassion that way and patience.
Oh, for sure. I think that it always helps to know like what gets missed when you have, you know, an obstacle that you're trying to overcome in the process. Yeah.
And I mean, you were talking a little bit about some of the strategies in terms of the equipment itself, but you are a behavior specialist. And I guess some of your behavioral strategies will apply to some of the other medical equipment that we talk about. So feel free to adjust how you'd like. But what are some of those go-to behavioral strategies that you would recommend parents, caregivers, educators try to help with, you know, their loved one or their student keep their hearing aids on, for example?
Yeah, absolutely. So the things that I start off with is one, where do you have undivided attention, right? Like where can you give undivided attention? So in a classroom, I would say don't start off with using, like for hearing aids again, for example, don't practice wearing hearing aids on the playground where our very savvy kids can hide and get rid of these things that are aversive. But like during that one-on-one time where you can also verbally provide a lot of reinforcement and a lot of like, praise for being able to do something that feels difficult and validating that. Once you kind of have your baseline data of like how long can a person, tolerate the equipment before they're done with it, then I think the big behavioral strategy is finding something that's motivating that can be really reinforced or can be the motivator. So when we were talking earlier about how a person with Down syndrome may not be, motivated to get used to the equipment, but they might be motivated by something else in their day-to-day life. Let's use that as the motivator. Sometimes people will tell me, well, but isn't that bribing them? And I'm like, it's either, you can look at it two ways. Either I, cross my arms and refuse and say, I'm not going to do it, and then somebody offers me something good, I would say that's bribing. And that's not an appropriate strategy. That's reinforcing the opposite of what we want to happen. But if you use first we're going to do something that's hard for you, and then you get to have access to all this great stuff. I do think that is a kind of a very core component of what I have found has been most successful. Some of the things that I talk to families about is when to dose or when to give the reward. So sometimes people will say, well, they love to watch TV. Can I use that as a reward? Yes. Sometimes we do it paired together, right? So you're doubly reinforcing. If I'm wearing hearing aids or glasses and I can see better or hear better while I'm watching TV, that can then be motivating to kind of be able to keep the equipment on. But we also don't want to have like 18 hours of TV in order to get our kids used to wearing it. So it might be that we start out with pairing them together, first put on glasses, then watch TV, and then you get whatever normal time that the families would allow anyway. And then the glasses, then all done glasses, we take the glasses off and then the TV turns off. And then, when we kind of get really good at that, then maybe the reward comes afterwards, right? So we wear our glasses for 2 hours or 3 hours, and then we get to watch TV afterwards. I would say you don't want to go much more than that as far as like when you would reward someone for the hard work that they're doing, because for our kids, rewards at the end of the week or at the very end of the day are just too far. Remember when I was talking about that working memory piece, is it just feels too far. So then it's not as motivating or as rewarding. Yeah. So to me, like those are, core components of what I use to help kids to get used to wearing their equipment, whatever it might be.
Mm-hmm. Great.
Mm-hmm. Yeah.
Awesome. And I think what that requires of us as the adult is to anticipate it so that you're not getting yourself into the oops bribe situation.
Yeah.
Oh no, now they've shut down and they're sitting in the corner and now I got to get them out of that. You want to be just like one step ahead and say, okay, we're going to do this thing that's tricky. Yep. How can I plan for that?
Yes.
And it's easier said than done, because when you're doing it all day, and your kid has 5 pieces of equipment, that's a lot.
Yeah.
That's the ideal.
Yeah. And I think for that very reason, I will also tell families, like, pick a time, when one can give a little bit of your undivided attention, recognizing, that households don't function like that smoothly all the time. But, and then picking a time that's like, kind of your regular time to practice. So it's no different than, brushing your teeth or taking a shower, that it's just a part of your day and it's a part of your planned day. And then even for adults, then it triggers us and going, hey, it's our practice time. And then being able to kind of go from there. Yeah. School's the same thing. Like if you have a regular time when you can practice, I do think that that's the cornerstone of then building on that success to then widen the amount of time that you're practicing. Mm-hmm. I really, really, the last thing I always say, like start during structured times or times when you don't have to kind of worry about things getting lost or, our kids being very savvy and getting rid of them. And so usually like public settings or car rides or, those two I think are the ones that I usually tell people to wait till the very, very end to get desensitized to, because that is a lot harder to do. And there's a lot more risk in that.
Yeah. Like
Absolutely,
structured
yeah.
time, also finding a time that the parent is the least stressed. So
Yep.
like coming home after school while you're making dinner is maybe not the best time,
Right.
you know? So just kind of, because the thing is, it is a stressful thing for parents. And
Yeah.
I mean, yes, it's a stressful thing for their kiddos, 100%, but it's also stressful for them because they're worried about the equipment getting lost, damaged, you know, like,
Yeah.
are you going to wear it? And so as we know, our kids are such good empaths that they will feed off that energy too.
Oh,
So
yeah.
if you're stressed about it,
Yeah.
then they're going to, you know, say, okay, mom's stressed when I'm wearing my hearing aids. That's a stressful situation for me. Never mind, not going to do it again. So just thinking of the
Yeah.
overall presentation as well.
Well, and I make a point, you know, for adolescents, it's a little bit different, but for, you know, not the majority, but a lot of the kids that I worked with were much younger. And so we make a point to say like the adult is the one who's in charge of the equipment. And so, you know, if for example, you know, kids are practicing while they're watching TV and then you're in a different room,
Yep.
and all of a sudden, like midway through a show, my hearing aids or my glasses come off, then we're actually reinforcing the opposite of what we want, which is, yeah, actually, I can get away with still getting the thing I want without actually doing the thing you want me to.
Exactly.
And that's a lot harder to break. So, you know, another big thing that I always say is adults put equipment on, adults take equipment off, you know, especially for our younger kids. So what we'll do is we'll say, you know, if we say we're practicing for 30 minutes and the timer, we're using a visual timer and the timer goes off, then if the kid takes the equipment off themselves right away, I actually have the family put the equipment back on, count to like 3, 1, 2, 3, and then say all done. And then the parent takes it off.
Yep.
Just to get them into the habit of saying like, you know, once they get like, you know, wearing the equipment all day, that at the end of the day, it goes in a certain spot, the adult takes it off and puts it. And then we can teach that as far as doing it yourself, but you're never going to get to that place if a child knows that they can take the equipment off on their own without adult directives. So that's another really important piece, I think, that happens when you can have that supervised time, even if it's just short little stints of time during the day.
That's a very good point. Yeah. Exactly. Yeah.
I'm going to bring this one up just for the families that are like, right now in listening, which is how do we undo?
Yeah.
if our students are at a point where, you know, they are fully in charge of their equipment and not in a great way, where yes, maybe mom puts it on, but student takes it off whenever they feel and as quickly as they feel, and, you know, going out as many windows as they feel they can access. I've seen that happen before.
Yeah.
What do we do? How do we?
Yeah, that's such a great question. Yeah. And I think, again, I would be out of a job if we couldn't come back from behaviors that were inappropriate that had been developed. We certainly, I think that I come across that more often than, you know, teaching a new skill beautifully where behaviors didn't exist. So, you know, what I would say is again, like go back to those basics. Number one is how long does the person with Down syndrome typically wear their equipment before they take it off? Number one. Number two, is there a certain setting in which they tend to take it off? Right. So I have kids who can't, it sounds so crazy, but I've had some kids who've actually been able to articulate this to me that when they're riding in the car, if they're on a highway, they can hear the like sound of the tires on the road, and it's really distressing. And so that tends to be when they take their hearing aids off, right? So to me, then we become proactive in being able to go, hey, I recognize that this is a hard setting for you. And in this car, maybe, you know, audiologists would kill me if they knew I said this. So I'm going to pretend like I didn't say it, but I'm going to say it anyway, which is I would rather kids wear hearing aids through the whole day and not wear them in the car if that's the distressing point.
Oh, yeah.
Or turn them off. Yes.
Yeah.
And so what I would do is then on the proactive side, we're getting ready to get in the car. I've observed enough that I know the situations that are most distressing. I am going to validate that that's hard. And I'm going to actually say, hey, you know, Joey, we're going to ride in the car. We're going to go quite a long way. Why don't we turn your hearing aids off? Right. So to your point, Marla, they're in your ears, but they're still we're solving the distressing problem, but we're also not reinforcing like them taking it out themselves.
meeting them
Yeah,
halfway.
backing it up kind of one step. And maybe that doesn't
Exactly.
work. And then maybe you do have to take them out.
Right.
But
cafeterias, right? Like, I mean, in my experience, and I've had a lot of it related to desensitization, the times when, once we've overcome the initial hurdle of this is new and this is different and I don't like it, the biggest challenge is certain environments. And the reality is that if we're telling kids that they can wear noise cancellation headphones in certain environments because they're too noisy and distressing, then why can't we tell them that they can turn their hearing aid off? Right. Like, I mean, I think that that's fair. So, I think that to me, like, absolutely you can overcome those situations that you've already maybe, unfortunately had a bad habit of developing. We've actually done some creative things where, like, if a parent was like, I absolutely want them to wear their hearing aids in the car, and I think they can handle it. There's nothing distressing about it. It's just that it's convenient, right? Like, it's my parents can't stop me from taking my hearing aids out. So we'll actually do like a 2-person ride. So we'll have somebody sit in the back with the person and then somebody driving. And then that person is giving a lot of reinforcement for good job keeping your hearing aids in, making sure that they're occupied, have something to do, something that maybe even reinforcing, like if it's hearing aids, for example, like a sound book that, or music or things like that, so that there's more motivation to leave them in. But we're basically practicing the new skill to replace the old way of doing it incorrectly, which was getting rid of it when it didn't feel good.
It's funny you bring that up, because I had a good friend growing up who was typically developing but had hearing loss. And she was actually told as a strategy to turn her hearing aids off, or to at least turn them down for places like the cafeteria, the school bus where there's lots of people, and on the highway. And if she was told that as an acceptable solution, I don't see, I think it's an education piece of, yes, we want our students to hear well all day. If they miss car chat or some of the things that are said in the cafeteria, the cafeteria is too loud for me. So I get it. Right.
Yeah, and that's such a good point, because the thing is, the goal at the end of the day is for them to be independent in using their equipment. So if they can understand that, okay, I need my equipment to work this particular way when I'm in the classroom. I mean, I turn down the volume in the car when something is too loud. We all have that power. Why shouldn't they? But I know when to turn the volume up, when I need to hear carefully and I need more information, and when to turn it down. So managing that is,
Yeah. And I think that to both of your points, I think we've gotten into this culture of over pathologizing, like, a lot of things that are very normal, right? Like, 100%. I mean, it's interesting because, like, with really young kids outside of desensitization, families will say, oh my gosh, like, my child is throwing things off of the high chair, like during mealtime. And I'm like, like little kids do that, but, and it is a developmental, like, stage, it's a stage of development, but we've somehow like said, because it's a child with Down syndrome now, it must be something that's a problem and not something, I'm not saying like we can't come up with strategies to address that, but also recognizing that it's typical at that time, right? Like it is very typical, and that we have to honor that. And the amazing thing, I just can't speak enough about all the great, like, ophthalmologists and audiologists and sleep docs that I've been able to work with. I've learned so much over the years. Like the fact that technology has become so advanced that you can have an app on your phone that can adjust the volume of your hearing aids. Like, mind blown. Like, I'm like, that is so cool. And like, I mean, it makes sense to me now after people tell me that, or the fact that you can stream, like, use your hearing aids as, like headphones, like,
Bluetooth.
Oh my gosh. Like, it's mind blowing on the one hand, but it makes sense that you should be able to do that. So let's take advantage of those things and, normalize that piece of it too, to be able to say, hey, different from when you're a little kid and parents need to dictate kind of what happens a little bit more. But as you get older, if the issue is no longer whether you're, taking equipment out because you just don't like it or it's new, then let me help you to transition into the developmental stage where you are taking ownership over some of that stuff yourself. I mean, I have adolescents who replace the batteries on their own, like do, maintain and care for their equipment as needed, or, we'll let, we teach kids to, and I say kids when I mean like the spectrum of individuals I get to work with, but, teaching them to advocate for themselves and saying like, hey, this isn't working, or
exactly
this is how I clean the water chamber for my CPAP. Like, I mean, that comes, but before that comes, we have to set up a very clear line and rule about an adult dictating when it happens, just because of those other pieces of resistance and refusal.
Yeah, exactly.
Yeah.
So, and I know, so like, let's move on to vision. And I know a lot of the behavioral strategies will apply to vision, and then we're going to move on to CPAP. But are there any strategies that you found that that are specific to working with glasses? Anything that's a bit different? Any stories that you've had, that things that have worked with clients in the past that parents can think about?
Yeah, I mean, I think that one thing that I would say, I mean, there's a lot of similarities. I mean, I think that I still check for like equipment, fitting and things like that. Again, because of some of the facial features of individuals with Down syndrome, glasses are a really hard thing to get just right? Like either the bridge of the nose is too short and the glasses are sliding down all the time, or they're pushed back too far and they're like basically touching your eyes. Yes. I mean, who would want to wear that all the time, right?
I know. And some of our students, like their eyelashes are touching the glasses.
Yes.
Every single blink.
Yes.
Can you just imagine how irritating that is?
Yeah. Absolutely. Or like the loops around the ears not being like, not sitting well enough because there's not enough of a dip, for the glasses to actually hold there. So I definitely think I spend a lot of time on the front end with trying to make sure that I'm working with the audiologist and saying like, is there a pair of glasses that, are a better fit? And there are, certain brands that, work better for individuals with Down syndrome, or I feel like have been more successful. But yeah, even that gets thrown a loop when you have a kiddo who has tried those and it still hasn't worked. So I definitely think that's a big piece. One thing that, ophthalmologists have kind of suggested that I haven't necessarily seen like a huge difference, but I would say that it is just another strategy in the bucket is I've had some ophthalmologists that will give dilation drops, like, to families to put into their eyes, because then it magnifies like the difference in what they weren't seeing to what they see when their glasses are on. And so it's almost like immediate reinforcement of just even having the glasses on, if that makes sense. So I have, maybe those are families that have been successful and then don't end up coming to see me. But I think that it's important to note that that's, something that is an appropriate strategy as well. The other thing that I think about is, for me, like depending again on the level of hearing loss versus the level of vision impairment, I find fatigue is a huge piece in glasses. I think it's true for both, but with glasses, I've actually noticed a little more like, with like not being able to tolerate it as long. And I there has to be something to that. I mean, I think, without knowing all the nuances and details of how, vision correction works. I mean, it is forcing your eye muscles to move in a way that they're not used to. And so I do sometimes have kids who, who can report to me that they get headaches. Whereas other people who can't report, but will take glasses off. And I always try to make the assumption that there could be something else going on that's causing that. And so I think that those are things to for sure look out for.
Yeah. And I'm glad that you mentioned the nuances, because there are so many different vision issues in individuals with Down syndrome beyond just the typical astigmatism or the near and, so there's difficulties not only with the physical aspect, but then visual perceptual issues, depth perception issues.
Yeah.
I know that, and we're hoping to have an ophthalmologist. And that's the other thing, the difference between an optometrist and an ophthalmologist. I'm finding that I'm trying to explain that to our parents more and more, that our individuals for sure need to see a developmental ophthalmologist or a pediatric neuro-ophthalmologist at least once or twice, because they are looking for things that are different than what an optometrist is looking for.
Yeah.
And once you kind of get a bigger picture and a better picture of what the actual visual difficulties are, then yes, glasses can help, but it can also help them navigate, how to help them get used to the glasses and get used to navigating their environment as well.
Yeah, for sure.
And I'm glad you're speaking about fatigue, because it's just part of it. I mean, I've had glasses for most of my life, and I still need to, just have a break from them by the time evening rolls around. So, expecting our students to wear glasses from 6:30 a.m. until bedtime every single day is probably not reasonable. So yeah, I think it's a lot of it's adjusting our expectations. With all the good ideas about how things are supposed to happen, but being a little bit more realistic, right? Because our students can't always tell us what it is.
Yeah.
But
and thinking about like not only like the fatigue related to having to like have that correction the whole time, but then the visual stimuli around you, right? Yes. Like how much are you actually having to navigate, in an environment? So, I have a lot of times when I'll talk to schools about having scheduled breaks. To me, that's how you avoid having like behaviors where kids will take them off themselves and throw them in the trash can because they're like, I'm done with this, is having those scheduled breaks where it's like, you get a break from your equipment. And I find that can be such an important and successful way to help kids to actually get used to wearing their equipment throughout the day much more effectively than if we kind of dismiss that piece and say, no, we just have to push through it, right? I mean, we get the option to not push through it all the time straight through. So why shouldn't we give that option to people that we care about,
Absolutely. Exactly. And again, it comes down to anticipating it, right? If we know that by 3 o'clock, we're over it with glasses, then 2:30, we give that break.
Absolutely.
Especially nowadays with so much increased screen time as well. That's just like extra tiring. So that break is needed.
It really, really is.
Yeah. Great. Okay. So let's move on to our kind of third piece of medical equipment, which is the Cpap machine. So during our second season of the LowDOWN podcast, we featured a few episodes focusing on sleep and sleep hygiene. We had Dr. Rafael Palaio from Stanford talk about sleep difficulties. And then we had Katie Frank, who I know talk about sleep hygiene, because we know it's a huge challenge for our loved ones with Down syndrome. So can you provide our listeners with just a brief overview of why sleep is an issue in this population?
Yeah, I mean, I think that there's components that we understand and components that we don't. I actually think that we need to do more research, honestly, on the non-traditional sleepers. So I have so many families that'll tell me like this, 2 to 3 a.m. wake up and they don't have sleep apnea. They don't have any like clearly identifiable sleep issues. The family has a great behavioral routine and sleep routine, of going to bed. They have great behavioral strategies for responding when kids wake up. I mean, they have all of those components in place, and still their child is like, hello, it's morning. Let's get started and let's move on throughout the day. And it's 3 o'clock in the morning. So definitely I see a lot of like atypical sleep issues that don't have kind of a clear diagnostic category. But then you have like the kiddos who, just have a higher frequency due to structural differences, who have sleep apnea or have some sort of more significant sleep issue, low ferritin levels, and have like restless sleep, disrupted sleep, which absolutely then impact kind of functioning during the day. So certainly we have, those components, and I think there is research that is being done, and that we do know that disrupted sleep really impacts cognition. We can talk about the global things of like, hey, I'm more irritable if I don't get a good amount of sleep. Sometimes people will say, hey, they actually slept throughout the night, but then we talk about quality of sleep too, right? And all of those things then, in a circular fashion really impact kind of the level of functioning and the, how our kids function during the day as well. Did I answer your question?
Oh yeah, 100%. And I think it's important. I'm so happy you mentioned that component, that the amount of sleep is different than the quality of sleep. Because I've had parents tell me so many times, well, they slept throughout the whole night, but are they getting that amount of oxygen that they need to regenerate and to kind of, get that rest and everything. So the quality is so different.
And that we're not going to know that, right?
We're not going
to know that because if they're,
how do we
I mean, I've had kids who like, unless there's like something obvious, like, oh, they're sleeping on the floor in the morning versus they're when they were sleeping in their bed. Like if it's not something obvious like that, or that they came and woke you up. I mean, there's a lot of quality sleep issues that we don't get to see, and one of the things that just drives me insane, because this is a component of desensitization too. Before we even get to the Cpap, desensitization to a sleep study. I mean, like getting used to having all the stuff on your face and on your head, and then being able to evaluate whether you had the amount or quality or whatever sleep that you needed in order to then get that diagnosis.
Or even the home study, like even the pulse oximeter test at home is not easy to do. So forget the overnight sleep study,
Exactly.
And I feel like such a, I don't know, I feel bad because I emphasize to families over and over and over again, this is important. We need to know if your child is getting good sleep, if your child is grinding their teeth all night, if they sleep sitting up, if this and this and this. We just have to do the sleep study. They go for this horrendous experience where their child, either didn't sleep at all that night in the hospital because it was so different and terrible, or they didn't sleep until about 3 a.m. and then they get kicked out at 5 a.m. I'm like, that's not what we needed from the process, because now we have either not enough data, or we're traumatized, or we're whatever.
And they're not going to go back for a second one now because they're like, no thanks. Yeah, I'm good. Yeah.
And I would venture to say that the same thing I was saying about using medical equipment is true for anything in life, which is if you're able to slowly make progress towards this end goal and then have a successful interaction related to it, you can go back and do it again, right? I mean, I've had 4-year-olds who have been able to tolerate a sleep study when their parents thought that they couldn't, that there's no way they're going to be able to do it. But I will tell you that I would agree with them 100% if we would not have taken a strategic approach with desensitization. I mean, like, taping yarn to somebody's face sounds super silly. But, without access to all the equipment that, you're doing, even those things are components with just helping people to understand that there's going to be a lot of things that feel different. But if I can get you to a point where you feel used to those different things, at least to some level, then your coping strategies kick in and you can absolutely do those things, even though it's not taking away the distress completely. It's taking it away enough that you can tolerate it for the amount of time that you need to tolerate it.
Providing some predictability too, right?
Sure. Yes.
I should be clear that lots of children can do a sleep study. It's not that it never works out. If you haven't done one yet, it can work out, but it needs to, be planned in advance. They need you to help them with that. You too. And you both.
And all of this stuff really comes down to, circling back to like what makes it harder. Our kids at baseline just experience a higher level of anxiety. I feel because they are the world is going in high speed and fast forward when they're processing a little bit more slowly, and they're missing a lot of key pieces of information. And so our kids are trying to be successful, but in a world that's not set up to kind of communicate in a way that, is conducive to their learning style. And so there's this, and so then they're kind of in fight or flight for a longer period of time, or, more easily than for another person. And when that happens, like that would be true for any of us. Like we don't function at our best. We don't access our best skill sets when we are anxious. And so if we are gradually introducing people to things that then they feel successful and they can tolerate, what we're essentially doing is helping them to stay at a level of anxiety that feels tolerable, and then experiencing that success. And then that then in and of itself is what results in people being able to work to their potential. It's using the skills that they have, but without this overlay of anxiety that makes any of us function in a way that's not as successful.
Yeah, absolutely. And I think I don't want parents or caregivers listening to this starting to stress out like, oh, there's so many different strategies for so many different things. But honestly, there's 3 or 4 or 5 top strategies that we always use to some degree when we're teaching a new skill for an individual with Down syndrome. So it's just adjusting that strategy for that particular situation. So yes, we're going to be working on, building predictability. So social stories can be across the board, building in practice time could be across the board. So it's not that there's all these individualized strategies. Like the concept and the theory is the same for across the board. It's just you're customizing it for your personal loved one with Down syndrome.
Absolutely. I think that's such an important piece. And so I think that, when I use the word desensitization, I typically use it in the context of medical equipment, but really those strategies that we're talking about, using first then, using a motivator, starting with an amount of time that's like your baseline tolerance, that's something that's tolerable. Those are things that you would say is true for life skills, right?
Yes.
And getting used to pretty much anything.
Exactly.
Yes.
Yeah. Great.
Absolutely. I mean, that's the fundamentals of any therapy practice, right? If we're learning a new speech sound, if we're learning to write, if we're learning to put on our own clothes. I mean, it's all the same sort of theoretical background, every bit of it.
Yeah, for sure. For sure.
Did
you want to talk CPAP, Hannah?
Yeah, sure. Well, I mean, you kind of mentioned a couple of CPAP strategies already. One of the ones, and it's great. I love that you have this source of information at the center where we have all these awesome audiologists, respiratory therapists. And I had a cousin who's a respiratory therapist that I just randomly messaged one day. I'm like, hey, like, what if, like the pressure is too much? And she's like, oh, you can actually change the ramping up of the pressure of the Cpap machine. So all these little pieces of information are so important. So can you just kind of talk about some of the few things that parents that are having a really rough time with in terms of adherence to CPAP that they can kind of look into to help their kids get used to it a bit more?
Yeah. So, I mean, one thing that I will tell you is that, we think of CPAP as like something that you do at, when you're sleeping, but really we start practicing during the day. And so, having like a 30-minute period of time where you're practicing during the day, no different than what we talked about with the other equipment, pairing it with something that's motivating or giving access to the thing that's motivating right afterwards. So that would still be true. And typically, if you're doing it during the day, you might do it with no air pressure to start with, right? Like, again, because that's kind of a second layer. If you're doing that, I would say don't practice longer than 30 minutes without air pressure, because then you actually see a lot of you can get skin breakdown just because of like the humidity that kind of accumulates in there because it's, static air. So then you talk about practicing, right at bedtime and seeing if the person is able to start falling asleep, right? With it on. And that's when you would introduce air pressure at a lower pressure. So I would say for parents, advocating and saying to the provider, I know that my loved one with Down syndrome is going to have a really, really hard time with air pressure. Here are some situations where examples of similar things that we've come across. Can we start at a lower air pressure? And I will tell you that most providers are not going to be like, no, we can't, we have to, because they know that you're still working towards the ultimate goal of the pressure that is being prescribed, right? And I say, if they get pushback, then in saying to that person, some air pressure is better than no air pressure at all, right? And if a person can't wear the equipment at all, then we're not making any progress at all. And so I do think that I haven't come across providers who have been, pushed back a ton on that. But I would say starting with a lower setting, getting used to that, then, so first get used to the mask being on your face, then get used to air pressure that's much lower, right? And that doesn't feel like it's, blowing and forcing right into your face, and then start gradually increasing it. And then use the ramp up setting so that even when you're falling asleep, it's not this immediate high pressure, oh my gosh, I'm supposed to fall asleep while this is happening. But really being able to fall asleep in a calmer situation with even light air pressure, and then the ramp up happening even when you're asleep already. Yeah. So I think that those are important pieces. I sometimes it's, one of the differences with desensitization for CPAP is you can't pair it with a motivator, right? Like, because you're asleep. So sometimes you have to get a little bit creative with how you have to, reward. One of the things that I've used is a visual cue, like right where if a person woke up, they would see it immediately, like a first then. So it's first a picture of them wearing their CPAP. And then the then is like, I get to pick breakfast, or I get to have access to the iPad, or I get to do whatever. And so it's at least a visual cue of, oh, I better leave this on because this is what I'm working towards.
Yeah.
I've also seen a lot of families, and by no means am I saying that this is what you have to do, but I have seen a lot of families who have basically said, look, I don't want to reinforce co-sleeping, but for CPAP, because the level of obstruction is so significant, we just need to get good at this, is that they will co-sleep with kids so they can keep putting the mask back on. And then we'll deal with the getting out of the bed at a later point in time. And usually what I'll tell those families is, if that feels like that's what's going to work best, great. But make sure that you are sleeping in their room and not that they're sleeping in your room, because it's easier to transition yourself out of a room than to have the person move to a different space. Yeah.
Very good point. Yes. Yeah. And I think technology is changing a little bit with CPAPs too. And I know the one thing that some sleep clinics will say is that there's different kind of masks. Like you can generally customize masks that will be more comfortable for individuals, right? Yeah.
Yeah. And I think that the mask fit is so important. I think that, just naturally, like, again, sometimes the challenges I see with CPAP is, even when kids have gotten used to it, it's more like I'm moving around and it moves and I don't know that it moved. And so, or I take it off in my sleep and I don't realize it, right? Because and usually what I'll say to those people is one, you might need to take a step back. If they're taking it off in their sleep, it might be that it's shifting, and that's part of, like, then, kind of how if you just bat something away, that might be part of the issue. And so sometimes it results in, hey, do we need to do more daytime practice? But other times it might be, can we get creative in how we wear it? If you've ever seen like the, for nasal cannulas, they have like these, like, hats that have, these loops that kind of hold the cannula in place. So, there are things that you can kind of makeshift to do to help the CPAP stay in place a little bit better too. I'll have kids who will wear sweatshirts, and we will actually like feed the tubing of the CPAP down the back of the sweatshirt to help it to not move around as much. So, there are things that you can do. Some people like need an extra long hose so that if they're moving around, it won't like tug at anything. So, that's where the creativity really comes in place is that sometimes it's things that are just like getting used to wearing the equipment. And sometimes it's like little things that would happen to anybody, right? Even the most motivated person to use their CPAP would still have those issues. So I think that's where we have to get creative.
Yeah, absolutely. Great.
There's one last area I wanted to talk about for today, which is what happens when your whole daily routine gets unsettled. So, these things are tricky, as we've discussed, for our students with Down syndrome. And sometimes things around you shift, like a pandemic, where your whole weekly daily routine is just out the window. And sometimes what we'll notice is that things that were going great, things that were part of the routine, also go out the window when, our school schedule and things just kind of disappear. So do you have any thoughts on what to do? Do we wait until regular life resumes? Do we adjust? How do we work with this?
I'm a big fan of not taking extreme measures unless necessary. And so to me, like, illness is a thing where I'm like, if somebody's sick, like, it is not fair to sit there and go, you have to practice and we have to do this, right? Like, so to me, it might be like either, like the best case scenario would be we still practice, but we practice just for a teeny bit of time, right? So that the routine doesn't get disrupted, but we're also respecting the fact and honoring the fact that this person is not feeling well, for example, or that their schedule is really disrupted. So to me, like ideally, that is what I do, is what is like the least amount I can do, but still do, so that the whole routine is not disruptive, and that the person, that my loved one with Down syndrome still understands that this is an expectation, that now we aren't absolved from, doing this at all. So to me, like that's the most important thing. I do think that, there are like inadvertent stressors, COVID, remote learning, like there's so many other challenges that can be thrown into the mix. And as long as we're not taking away this as an expectation completely, I do feel like you can build back up on your time. You know what I mean? But if it's like, if somebody's sick and then they don't see the Cpap machine for like a month, I will tell you, you are going to be starting from scratch.
Yeah.
But if you are practicing every day, but just, teeny tiny bit, I do think that then it still stays relevant to the person. And they'll pick it back up a lot more quickly.
Mm-hmm. Yeah. So you're saying it's kind of about keeping the door open, right? Just keeping our foot in the metaphorical door, just so that, we keep that open as an option, or as a thing that we're going to be still doing, but adjusting our expectations around that. I think that makes a lot of sense. For sure. Yeah. I mean, because, thinking about, we're going to wear our glasses all day at school. Well, if it's remote learning and school, is now 2 hours a day, everything can just change and be different sometimes.
For sure.
Have any resources or things that you have that are go-tos that you'd like to share with our listeners?
Go-tos.
It could be like websites, books, anything, and then we can put it on our episode page just so people to
sift through.
I feel like a lot of the things that I there are resources that I can certainly send you guys that I've made along the way, that I feel like I have a little like desensitization, like step by step, that I give to families. Like if they're coming from another state and I won't see them as frequently. So I can certainly send things like that to you. I can put in a little plug that it won't be probably next year. We're actually working on a book on desensitization.
Awesome.
So Woodbine House Publishing is going to be publishing that. And so I'm writing it now, and hopefully that'll become like a good resource for, kind of like more of that step-by-step process and kind of a more detailed view. I think that, I can certainly pull together some resources for you guys and share those. Yeah.
And speaking of books, speaking of books, I finished reading the toileting one you guys wrote, and it's fantastic. So it's really great. It's great because like our approaches are so similar to what we do at DSRF. So it's so cool to kind of get that, like, I love that I don't want to go into toileting right now, but I just like that you give a full picture of the whole thing. So it's not just strategies, but like, what are some of those medical things to look for? What are some of the other things to look for? So that whole big picture is so important, I think. At the end
I feel really lucky to be able to have worked with so many amazing families with Down syndrome for so many years, that they've taught me so much, and the kids have taught me so much. And it's a blessing that I have this opportunity to be able to put it into a book to hopefully share with people who may not have access to Colorado, or being able to come to our clinic and actually meeting with us in person on a regular basis. So thank you for reading the book.
It was great. I'm very excited for this desensitization one now. So it'll be awesome.
Awesome.
Yeah. Thank you so much for joining us.
Yeah, it's been a pleasure.
Thank you so much for the opportunity. Anytime. I'm at home so much now that like the conversation is like even more refreshing than it would be at other times.
We would love to have you back on for another episode in the future for sure.
Oh, sure.
Awesome. I would be so happy to join.
Yeah. That'd be awesome. Right. Well, thank you so much.
Yeah.
And take care.
You too.
Okay.